So it's a pleasure to be here today to talk about clinical decision support systems for focusing on optimizing patient outcomes in the diagnosis and management of bloodstream infections and sepsis. And today, what I wanted to do was take a slight track change and just first of all think a little bit about what we mean by clinical decision support systems, think about some of the current challenges associated with them, and then think a little bit ahead about how we can begin to be more precise and individualized in the way that we use data available to us to support decision making in time-critical situations like syndromic diagnosis of sepsis. And so for that, I'm going to talk a little bit about artificial intelligence and how give some examples of how it's being developed to try and apply it into this field. But to start with, let's just think about digital health technologies. On the broader sense, digital health technologies may improve the efficiency of healthcare systems. They might help us deliver targeted and individualized patient care. They can support sustainability and equity where digital services are available. And when we think about using digital health technologies to support infection management, we often think about health information technology. We think about electronic health record systems, laboratory information management systems, and rule-based clinical decision support. But there's actually a huge amount of other areas where digital health technologies are being developed, and particularly around precision approaches to guiding treatment. So we've heard a lot about molecular diagnostics and point-of-care technologies, but artificial intelligence is another area where we're beginning to understand how this can be applied. If we think about clinical decision support systems more generally, these are just electronic tools which help healthcare professionals or patients make decisions about their healthcare. Clinical decision support for infection management has exponentially risen in line with our adoption of electronic health record systems. But despite this, in secondary care particularly, there's very limited high-quality evidence to support their application and use. If we think about targeting individual prescribing behaviors, we know that clinical decision support systems have good evidence to show that they can reduce your overall antimicrobial consumption, they can promote adherence to guidelines, and they can have some economic benefit for your hospital. However, there's very little direct benefit for patients demonstrated in the literature at present. When you look at the implementation of traditional clinical decision support as well, there's a nice quote that I always use from Kieran Hand's paper in 2021, which essentially said, you see early enthusiasm and adoption of these technologies. People report good feedback on their usefulness, but over time you see a risk of waning effect on the appropriateness of decisions being made based on these decision support tools. And when you look into this in more detail, it's often because these tools have a very narrow focus and they often fail to provide the flexibility in the face of inter-individual variations, which we see routinely in our clinical practice. We do know that clinical decision support systems can be really successful, however, particularly when they're integrated with a much wider stewardship program. And I think this is a really nice example back from in 2017 of the application of a support system linked with a pharmacist-led prospective audit and feedback approach. It was analyzed over a 6-year period in an interrupted time series format. And we can see from the figure here that actually implementation of this tool within a much wider stewardship program can lead to quite significant reductions in antimicrobial consumption. It can save money for your spending on antimicrobials. It can actually have some impact on patient length of stay, and it can help avoid inappropriate prescribing. And I think the real takeaway from this is that applying these tools in this fashion leads to a high rate of acceptance of your interventions because it's built within a robust and broad system within your institution. So thinking a little bit more on optimizing decision-making in bloodstream infections and in suspected syndromic diagnosis of sepsis, I think it's also important for us to think about the sort of complex nature of decision-making that we have to go through as clinicians. We know that decision-making, particularly in those early phases of management of an unwell patient, goes through a number of different stages. And at each of those stages in the decision-making process, there are a huge number of factors which we have to try and compute and make best practice decisions based upon. If we think about patients presenting with septic shock, there's also additional challenges there. There's that time-critical nature of us needing to make a decision. There's balancing and the perceived risk of balancing inappropriately narrow-spectrum antimicrobial therapy versus inappropriately broad-spectrum therapy. There's the challenge of the time and turnaround time delays we have in culture-based diagnostics. And there's the importance of thinking about how we can optimize novel technologies and new technologies as they come online, like molecular diagnostics, to optimize decision-making for patients where it really matters. And then what we have to do is step back and think about how we take all of this information and deliver it in a way that addresses some of those significant behavioral elements and biases that we see in delivery of evidence-based medicine in these time-pressured situations. So one way we can start to think about that is beginning to design clinical decision support tools in a way that optimize the use of all of that data that's being generated. And some of the approaches that are being taken are beginning to take more development of more intelligent tools. So using things like machine learning and artificial intelligence, spending much more time focusing on end user engagement in the initial design, and making sure that these tools are flexible to be able to be integrated and used within your local institution. There's also a big focus on moving away from focusing on single decision aspects to taking a more augmented approach to decision support. Can I begin to embed within my tools, not just thinking about optimal antimicrobial selection based on the information that's becoming available, but risk prediction, forecasting? Can I think even about how I can use these tools to communicate better with patients about what's going on? And the hope is that by taking these approaches, we begin to develop a more individualized and adaptive approach to managing the patient in front of us through using data more efficiently. So, particularly this year at ESCMID Global, there's been a huge number of abstracts and reports on artificial intelligence for infection management across the board. But I think it's important just to remember that using artificial intelligence approaches to support empiric antimicrobial prescribing isn't actually new. Back in 2006, there was a publication of cluster randomized trial of a causal probabilistic network, which demonstrated improved appropriateness of empiric antimicrobial prescribing compared to control wards. It favored patient and economic outcomes, but the big challenge was that actually it failed in intention to treat analysis because clinicians simply didn't engage with the recommendations and follow them. We're also now beginning to understand that in complex situations like septic shock, focusing just on antimicrobial prescribing probably is also a little bit too narrow when we're developing these tools. And there's been some really nice work over the last few years thinking about how they can develop different types of artificial intelligence approach to address other aspects which are also critical to improving outcomes in the management of patients with syndromic diagnosis of sepsis. So I think this is a really nice example by Komanowski and colleagues. It was published in Nature Medicine in 2018, essentially developing a reinforcement learning approach to optimize fluid and vasopressor dosing within patients with sepsis. They were able to take a large number of patients from an open source critical care data set, MIMIC-free, select 48 variables and train a Markov decision process that was able to favor 90-day survival in patients. And the interesting thing here was that the AI clinician, as they termed it, began to recommend lower doses of IV fluid versus higher doses of inotropes. And actually, when clinicians were following this in practice, they seemed to be associated with lower mortality. So I think just important to highlight here that although we think about decision support from antibiotic prescribing diagnostics, in these situations, we can think much broader around optimizing empiric management as well. For the second part, I just wanted to think a little bit about how we can also support diagnostic decision making. This is an old example now of some work from between 2015 and 2018 that we undertook at Imperial College as our electronic health record systems matured, where we looked at developing different types of prediction model which would help infer the likelihood of a patient having an infection and also guide decisions about where the most likely positive site from sampling from a microbiological culture would be. So just to sort of show you how this works, during rounds, you were able to input data that wasn't available electronically at the time. We were able to extract automatically in real time data from the laboratory information management systems. And you could feed this into underlying algorithms, such as support vector machines, which would provide you a likelihood on that given day of a patient having an infection that was bacterial in origin, and also would guide you on a prediction of the most likely site where you would have a positive microbiological culture based on prior experience. You could then feed this back into a number of different case matching recommendations, which would give you individualized treatment recommendations, which had a high level of appropriateness, but tended towards recommendation of slightly more narrow spectrum antimicrobials compared to what was happening in normal practice. But the big challenge with these type of approach is that we often use static information to make single predictions looking into the future. And actually, a way of being able to much more efficiently and optimally use data is to begin to incorporate time series data with deep learning approaches, such as long short-term memory models. And there's been some really nice work by Damien Ming and Bernard Hernandez recently looking at this and saying, okay, so over the course of someone's journey through hospital, there is a change, and a temporal change in their biomarkers, in their vital signs, and how do we capture this and incorporate these changes and trends into our prediction modeling? And I think the really important and really interesting thing to take away from this is that compared to static models, these type of time series data being incorporated is leading to really significant improvements in the predictive performance of models. And I think opens up a huge range of opportunities to be able to refine some of the predictive models we can use, particularly during those early phases while we're trying to think about collecting appropriate microbiological samples and guide our decision making in terms of diagnostic stewardship. Very finally, I also just wanted to think a little bit about what there's actually been quite a lot on at ESCMID Global this year, about using machine prediction of antimicrobial susceptibility. And I think one of the biggest challenges is for us still in our clinical practice is beginning to understand how we bridge that gap between our reliance on phenotypic susceptibility data to make definitive decisions and the opportunities and fantastic ability to be able to get more information earlier through the application of things like molecular diagnostics. Now, one of the potential ways to bridge some of this is to begin to think about how you can use prediction modeling to try and estimate or predict the susceptibility profile of organisms based on clinical information. And there's been a huge amount of work looking at AI prediction of susceptibility. But I think it's fair to say that this has remained challenging using current clinical biochemistry and microbiological laboratory data. There's been some interesting progress, particularly in predicting drug resistance for specific drug-bug combinations like fluoroquinolones and sepsis. But the data overall has been variable in terms of performance. But there's some really nice examples of how this technology is being thought about and developed to help us take a much more sort of system-level approach to making decisions. So not only can you begin to predict susceptibility, but you can also incorporate weights and penalties into that system, such as Corbin and colleagues did here in the personalized antibiograms figure, where you can say, not only am I going to predict the most likely agent that's going to be susceptible, but I'm going to think about the potential ecological impact of that or financial costs on my institution between one and another agent. I think also looking forwards, there's a huge amount of work that's been reported this week alone looking at the application of artificial intelligence with genomic and molecular diagnostics. And I think that the data is now starting to begin to emerge that may facilitate much more robust predictions of things like minimum inhibitory concentration data. And it's going to open up opportunities to bridge some of those gaps between suspicion or syndromic diagnosis and confirmation of phenotypic susceptibility. So, I hope that today we've taken a slightly different track with the last talk, but I've shown that clinical decision support systems have the potential to help us support not only clinical, but also hopefully diagnostic decision making. There are several advances in approaches to artificial intelligence, which have a potential to help us shift some of the approaches we have in our traditional thoughts about the diagnostic pathway. And we're beginning to see a range of tools emerging to support prediction of infection likelihood, microbiological sampling strategies, personalized treatment decisions, as well as better understanding local resistance trends and patterns. But I think, as all three speakers have said today, all of these tools are only really working at their best when they're integrated within a much broader stewardship program and not used in isolation. There are also several challenges and barriers which we haven't touched on in too much detail today, which remain to be addressed, particularly around things like regulation and integration with electronic health record systems. But I thought just to leave, I would leave you with a quote which I always have really enjoyed since it was published in JAMA in 2018, that we get very anxious and concerned about the role of these different types of technology, but at the end of the day, what the computer needs is a good physician. And so as long as we can create tools which work with the physicians, hopefully they will be a support for us and not a hindrance. So thank you very much, and thank you to everyone who's contributed to this, and looking forward to taking questions.